Okay, great. Thank you. Members of the Select Special Committee to examine safe supply, good afternoon. I know you've had a long afternoon, so thank you very much for the opportunity to speak with you today and share my experience. I have been a physician in Ontario for over 35 years. I have worked in primary care and as an acting medical officer of health. I have a certificate of added competency and focused practice in addiction medicine and palliative care. My role in addiction medicine has principally been to offer an inpatient consultation service in an urban hospital. Most of my addiction work involves seeing patients who are admitted with infectious complications of injection drug use. From 2012 until 2021, I was the only physician in my city working in this capacity. I provide a non-judgmental, client-focused approach using harm reduction strategies, meeting people where they are. I initiate or continue opioid agonist therapy as patients are ready and connect them with appropriate community resources. We now have what is referred to as a safe supply program in my area. It is delivered at the Intercommunity Health Center. Because it is run through a community health center, it is associated with wraparound services such as primary care and housing first initiatives. These additional services have been shown to improve health outcomes. The initial inclusion group for safe supply was women who were street-level workers at risk and who were experiencing homelessness or were vulnerably housed. This program has since expanded. In my experience, this safe supply program involves prescribing opioids, often in large amounts. While the program promotes daily dispensing, many patients that I saw receive scripts for several days, even 1 to 2 weeks at a time. The most commonly prescribed drug is immediate release hydromorphone tablets, also called Dilaudid or D8s on the street, as they usually are 8 milligram tablets. Cadian, a long-acting morphine capsule, is occasionally prescribed. Also, I am aware that some clients have received injectable hydromorphone. Now, it is important to recognize that clients receive a prescription that they fill at a pharmacy. Taking the pills or medication is neither verified nor witnessed. This should not be confused with a witnessed injectable opioid agonist therapy program. This safe supply program is not part of and does not provide a supervised injection site. Initially, I was supportive of safe supply. Locally, we had had a huge problem with heart valve infections called tricuspid valve endocarditis, as well as an increase in HIV in people injecting drugs. In listening to their stories, I discovered that patients with these infections were injecting hydromorphcontin, long-acting hydromorphone. Working with infectious disease and research experts, we were able to prove and publish this causality. After the safe supply program started, I noticed an increase in horrendous infections. These included spinal osteomyelitis, an infection of the bones of the spine, epidural or spinal abscesses, at times causing paraplegia, and brain abscesses. Previously, I had rarely seen these infections, and I wanted to understand why they were increasing. In speaking with these patients, I discovered that approximately 90% were injecting Dilaudid. While some of the patients I saw were in the safe supply program, over 80% were not. They were buying drugs diverted from the safe supply program. Their experience, suffering, and deaths are not captured by data provided by the program. The number of people suffering and dying from infectious complications of injection drug use in our region is high. We found that at least as many people die from infections from injection drug use as from overdose. Since safe supply began, I had a significant decrease in patients who would consider initiating or continuing evidence-based opioid agonist therapies, such as methadone or Suboxone. Increasingly, patients requested safe supply, even those who have been stable on an opioid agonist therapy. Many acknowledged that they were motivated by the income associated with diversion. When I first began my addiction work in 2012, most of the patients that I saw had developed an opioid addiction after being prescribed opioids for chronic pain. This has changed since Safe Supply. I am seeing much younger patients who have started by taking diverted opioids. The flood of diverted opioids on the streets has led them to be relatively inexpensive. It can be cheaper to buy a D8 than a beer. This has led to an increase in the number of people using opioids. People can afford to use higher doses. This in turn has resulted in an increased demand for more potent opioids, ultimately increasing the demand for fentanyl. I have also had patients who are in the Safe Supply program that divert their Dilaudid to buy fentanyl. This does not exclude them from the program, even if they are not using any of their prescribed Dilaudid, as the program generally does not perform urine drug tests. In our community, there is more fentanyl now than before the Safe Supply started. We have had an increase in deaths from overdose. I personally have witnessed much suffering and death as a consequence of infections caused by injecting Dilaudid, which patients informed me that they got from the Safe Supply program. I have also had patients that died of overdose who were in the program. For me, these are not statistics. They are people that I knew, valued, and cared for. I am here today to honor them. My commitment has been very personal. From 2015 until 2021, I lived within 1 kilometer of the Intercommunity Health Center. I chose to live in this amazing, diverse neighborhood to actively promote harm reduction and be part of a community in which a supervised injection site was being considered. Going for a walk often meant chatting with people who had been my patients and truly meeting people where they are. This was my home. I moved into the neighborhood before the Safe Supply program was a concept. I watched the community change firsthand. These changes included public health outcomes and concerns. A large amount of diversion has been from one specific pharmacy located near the Intercommunity Health Center. This has led to an increase in people staying in tents in surrounding parking lots and in neighboring storefronts in order to get quick access to diverted drugs. I knew many of the people staying in these tents, some who were experiencing homelessness, and others who were actually housed. These conditions are very unsanitary and may explain some of the increase in infections. Local businesses are also affected, as accessing them can entail stepping over drug paraphernalia as well as human feces. Storefront windows have often been broken or vandalized, resulting in some businesses closing altogether. In my personal experience, crime in the residential neighborhood has also increased. This includes things such as bicycle theft, car break-ins, and stealing copper pipes and wiring from homes. I understand that this is generally not from people in the Safe Supply program, but largely from those requiring money to buy diverted drugs. I have family in other parts of the city that are socioeconomically similar who have not experienced this increase in crime. Finally, sadly, because the program is not witnessed, vulnerable clients at times must surrender their prescribed drugs to other more dominant members of the society or community, or are at risk of physical violence. These victims can be the same people that the Safe Supply program was initially intended to help. Members of this committee, we are in a crisis. We need to be open-minded and innovative in our approach to solving this crisis. We need to reduce harm, not just pass suffering from one person to another. Unfortunately, a program that involves prescribing large amounts of unwitnessed opioids has unintended side effects. Diversion causes great harm. In my experience, it has led to an increase in the number of people using opioids and the use of higher doses. As people seek a greater high that cannot be met by prescription opioids, they may turn to toxic fentanyl. Community safety may be compromised as people seek ways to pay for diverted drugs. And as I can attest to, injection of pills designed to be swallowed can cause tragic suffering and death. The flooding of prescription opioids onto the streets started this crisis. We need to be more creative and passionate to end it. Thank you.
Thank you. Thank you, Doctor, for the presentation. We're now going to open up for members to be able to ask questions, and we're going to start with MLA Milliken.
Thank you very much, Chair. Thank you, Dr. Koivu. I want to express my thanks. Obviously, you're on the front lines with regards to healthcare, and so I'm sure not even just with regards to the issue that we're talking about today, but obviously with the experiences that we've all had for the last couple of years here. So again, I do want to thank you for all that you've done. And given that you have what seems to be a pretty solid wealth of experience with regards to on the ground of safe supply, I just want to take, I can't help myself, I have to take the opportunity to say, okay, if I was to champion safe supply, and if I was to get it to a point where we were potentially doing safe supply in Alberta, what would you do if given the opportunity to kind of help out with creating it, given your experience, to make it as safe as possible if it was instituted? And what I mean by that is you mentioned a few things like historically it sounds like urine tests aren't often used to ensure that individuals are taking what they're supposed to be taking. Perhaps ways to decrease some of the different infections that you had mentioned. Perhaps another one just off the top would be witnessing, things like that.
Okay. I guess I'd start by saying, getting feedback, sorry. I think it's hard to make safe supply safe. And there are safer medications such as Suboxone and Methadone that we need to have a lot better access to and wraparound services attached to those. And we can talk about that more. But there are things that can make safe supply, even the concept of it, less destructive than it is now. And I understand the moral injury of watching people suffering and dying and wanting to do something to help that. But the problem with safe supply as it is now is for every person you are helping that you can see that's in front of you, you could be harming one or two other people that you don't see. So you can feel good about what you've done because the harm you're doing might not be visible to you. And one of the most important things if people decided to have a model of prescribing opioids would be witnessed. Any of the things that even the people who promote safe supply say are helpful would still be there in witnessed drugs. And witnessing means you know what they're taking, you know how much they're taking, and you know that you're not adding to someone else who might develop an addiction from the pills that you're prescribing. And I think witnessing to me is the most important. And even things, when people come into the hospital and they haven't had witnessed doses, it becomes very confusing to know what a safe dose is for them because we have no idea how much they're diverting. So normally you can look at what people are prescribed and know what they need. It's completely different and very challenging in hospital to work with people who are in a safe supply program because we don't know what they're taking. And I've had patients who had severe problems such as COPD that were diverting most of their drugs, but if they happen to take them or witnessed, are at risk of dying. So I'd say witnessing is the most important. And the next one would be tying it to a supervised injection site. So if we are, giving pills is not a good thing. if people are injecting, it would be better to be a type of medication that was supposed to be injectable, but also having the injections in front of you in a supervised injection site would be paramount.
Just as a very brief follow-up, you had mentioned perhaps alternatively, or you had mentioned some wraparound services. What would you have been indicating with that?
Well, if you look at a community health center, they have primary care. So whether it's through nurse practitioners or family physicians providing primary care, they often have social work, counseling, housing first models to help people get housing. So the other social determinants of health that we know help people with who are experiencing homelessness, vulnerability housed, or at-risk populations, those services are at a community health center. And in where I live, for example, if you go to a methadone clinic or a clinic like a rapid access addiction medicine clinic to get Suboxone, buprenorphine, they're not available as part of the service, I think, and which makes it very, very unfortunate, because those are things that are needed to help with anyone's health outcomes. So I think ideally, wraparound services, so primary care, helping to treat people and get people back, helping with vocational training, getting them back into the workforce. All of those things that can be available through a community health center need to be available for people who are using methadone and Suboxone. They shouldn't be essentially discriminated against for choosing an opioid agonist therapy that is evidence-based.
MLA Amory.
Thank you very much, Chair, and thank you, Dr. Koivu, for your obvious passion for this area. It's incredibly important to hear from what you had to say. I'm going to start off by reading a little bit of history about what I have in front of me, and then I'm going to ask you a couple of questions about that, if that's okay. In March of 2020, you published a study titled New Hepatitis C Diagnosis in Ontario, Canada, are associated with the local prescription patterns of a controlled release opioid in the Journal of Viral Hepatitis. The prescribed opioid is safe supply hydromorphone. The study concluded in part that their findings add support to evidence that hydromorphone controlled release use is contributing to hepatitis C virus spread in Ontario. You have provided us in your presentation today with a lot of extra details in relation to some of the impacts that you have observed over the years. Notably, you've said that you've noticed an increase in health-related issue, transmissible diseases, and other related concerns, which you've articulated in your initial part of your presentation. You also talked about the impact on younger patients and the exposure that you are finding with respect to opioids because of their abundance in the market. These are, in my view, some of the foreseeable consequences of increasing the opioid supply in any community. But I was also a little bit surprised to hear when you mentioned that opioid-related overdoses also increased in your observations as well. Now, that was my preamble. My question is relatively straightforward. You had mentioned in your presentation earlier that you had approached the concept of quote-unquote safe supply with an open mind, maybe even a favorable position at the very onset. I like what you said earlier to my colleague, MLA Milliken, when you said that we all have an inherent desire to do something to help those in need when we think that we can contribute. I think you're absolutely correct about that. But I'm also wondering if you can comment for our committee's benefit what information or beliefs or positions you had at the very beginning when you were contemplating a favorable approach to safe supply, how that evolved, how long it took to shift towards this current position, which I believe has changed significantly since that time, and what sort of impacts you've observed in your community with respect to the damage that it's caused in that period of time. I don't think we can afford to have a trial period given that you've already experienced some of these things. And I'd like to hear from you about what has transpired since then. I think it's preferable to hear it from somebody who's gone through it than to try and have it exposed to this province here and find out firsthand. Thank you.
Thank you. I hope I can explain this in a way that I will kind of explain my experience. So in London, actually, I'll just sort of step back. I was a palliative care physician, and I started seeing a lot of patients who were dying of infectious complications of injection drug use. That is what brought me into working in addiction. And particularly the problem we had in London was a heart valve infection, the first heart valve that enters your heart from the bloodstream, called the tricuspid valve. We also were having an increase in our HIV and Hep C, but it's rare to see an increase in HIV and injection drug users. And we found that it was the long-acting, so it's a type of hydromorphone that has beads that were creating this problem. So when Safe Supply came out and they were going to be using a different formula of hydromorphone, the long-acting, they were using long-acting before. They were going to be using short-acting, which looks like it dissolves better. I actually thought that might be an answer, that we would have a safer type of drug that you could be giving to patients and decrease the amount of infections. But what I saw, and in a way doesn't surprise me retrospectively, was I saw that we were getting different infections. And in some ways, they were more horrific, because I started seeing people, particularly with spine infections, that were making them potentially paraplegic, so they couldn't walk. So the suffering, there might be less death, but the suffering that I was seeing from these infections was absolutely horrific. And even the suffering I see in palliative care couldn't prepare me for this suffering. And I didn't, as I said, I didn't know what drug people were taking. I had really good relationships with my patients and have for a long time. Being the only one who sees these patients, I had the ability to talk to essentially everybody admitted to hospital about what they took. And the thing that was most striking was that the vast majority of people were taking Dilaudid. So the immediate release Dilaudid that now was flooding our community because it was coming from Safe Supply. And I realized that we had traded one bad thing, tricuspid valve infections, for another bad thing, spinal infections and other infections. And we've actually shown that even though we had a campaign to educate about the tricuspid valve infections, overall infections in our community has increased since Safe Supply. And these are overall horrific injection drug use infections. So I actually thought naively that if I just tell people what I'm seeing, it would have an effect. And I was kind of surprised that when I was saying I'm seeing some really bad things, it didn't seem to have the impact on the people prescribing Safe Supply that I was hoping that it would. It's been really hard to watch that suffering. I can't describe how hard it has been. And people that I have known for years who've had developed much more severe infections. And I have patients in the program who have died of overdose that I'd known for years. So I've been touched watching how what I get to see are the ones that are suffering and not doing well. And as I pointed out, I lived in that community. I moved into that community knowing it was kind of an edgy, urban, diverse community wanting to promote harm reduction. Normally I'm the radical in a room where I'm the one really trying to support kind of meeting patients where they're at. I wasn't prepared for how the community was going to change. As I said, people were now living in tents in parking lots behind the pharmacy so that they could get the diverted drugs quickly. They're cheaper in the morning than they are in the afternoon. And the impact that all of that has had on our community is really hard to explain to someone not living there. There's a hypervigilance that you have to have that you don't experience when you live, in a rural community or even outside of this community, to know what it's like to really live where this is all happening.
Emily, do you have a straightforward supplemental?
Straightforward, direct. Dr. Koivu, thank you for your impactful response. Increased drug overdoses, deaths, increased social impacts, increased drug use, increased diseases, increased infections, increased exposure to younger communities. Can you describe whether you've observed any perceived benefits touted by safe supply advocates in your community?
I will say I have not seen the benefits, but I will also say that the people that might benefit are then not necessarily going to be in hospital. So I can't say that there can't be benefits to individuals and anecdotally, but I can honestly say that I have seen no benefits, and I have seen horrible experiences both for the patients, the increase in drug use, as I say, the increase in deaths overall, and then the changes in the community. So I have not seen the positives.
Emily Yao.
Thank you so much, Chair, and thank you, Dr. Koivu, for taking the time to speak with us. I'd like to just expand on Mr. Amory's last question to you. Early in your presentation, you mentioned first-stage housing, and that aspects like that have demonstrated to provide effectiveness for people that are trying to rehabilitate. That segues into a conversation we had with a previous presenter on Maslow's hierarchy, and that if we can address their certain needs like their physiological needs like food and clothing, their safety needs like their housing, and their social needs like having peer and family support, that those are proven supports to helping people kick the habits, if you will. What is that a fair estimation on your part that those are proven supports that we can try to address with people over these issues of safe supply?
Absolutely. I mean, if we look at addiction, we used to talk about pillars, which would be prevention, treatment, harm reduction, and enforcement. And we sort of now put all of our weight into harm reduction. But part of treatment isn't just the treatment with the medications like methadone and Suboxone, which are proven evidence-based treatments, but they also include looking at social determinants of health. And we know that they have an impact on outcomes. Unfortunately, they're attached to the community health center, and instead of that being a place where people go to get their evidence-based medicine, they've been connected to the Safe Supply program. So yes, absolutely, connecting those same wraparound services to evidence-based opioid agonist therapy that already exists, such as methadone and Suboxone, would absolutely likely improve outcomes.
I'll follow up.
Excellent. Any other questions from members? All right, seeing none, I want to thank you, Dr. Koivu, for joining us here today and for your presentation and your obvious passion and heart for the work that you do. So thank you, and we really appreciate your time.